We are still busy with the Mother Baby Friendly Initiative Session 5, which is all the possible problems from the mother. And in this lesson 2, we are going to do the different nipple conditions. Okay, so as I've said in this lesson, we are going to talk about the different nipple conditions. Now, the first condition that we're going to talk about is nipple pain. And we're going to talk about nipple pain, first of all, in general. It's a common early postpartum concern and a primary cause of early discontinuation of breastfeeding. I think all of you who are working with breastfeeding mothers have experienced this already. It's such an uncomfortable condition that if mothers suffer from this and she's struggling with breastfeeding, she very quickly decides that it's just not worth the while. So it's quite it's a common problem, but can be have a severe consequence in the sense that the mother discontinues or might discontinue breastfeeding. It can be the result of physical or mechanical trauma, or it can be the cause of an infection. And these are basically the two conditions that we are going to talk about now. Or it can be only because of some other conditions as well. And the pain can range from mild tenderness to stinging, itching, burning, stabbing, aching, sharp, dull, or even excruciating pain. I think that you will all know from maybe your own experience and from others' experience that this is quite a sore situation. It can occur at the start of a feed, or it can occur throughout the feed, or it can persist long after the feed, or even occur between feeds. Now, usually this with the start at the feed and throughout the feed are usually the nipple pains. We will come to that again. That's been caused by mechanical problems, and these mechanical problems are usually the way in which the baby sucks on the nipple. And then the others that persist after feeds and between feeds are usually nipple pain that's been caused by infection. Now, the quality and the characteristics and the duration of the pain, as I've said, might help us to identify the cause and the direction of the solution. Now, as I've said, most nipple pain falls into two general categories. The one is early onset, and that's usually the nipple pain due to mechanical reasons, mostly sucking of the infant, and then also a late onset, which is more likely to be related to infection. Now, early onset nipple pain occurs usually during the first week of postpartum. It usually peaks between the 3rd and the 7th days of the postpartum period. And this pain typically occurs as the baby latches on the breast, and it might last for 20 to 30 seconds or even for the entire feed if the baby has not been latched properly, specifically if the latch is shallow or suboptimal and the baby basically just suckles on the nipple instead of drawing the whole nipple and the areola into his mouth. As I've said, these pain are usually mechanical in origin. They are being trauma that's been caused because of inappropriate or abrasive pressures on the nipple skin in the wrong way and not from infection or organic conditions. As we've said, the late onset pains are usually due to infections. Now, one feature of mechanical pain is also a change in the shape of the nipple. If the baby is sucking on the nipple and the nipple has been removed from the baby's mouth, the nipple might have a different shape. It might be peaked, it might be wedged shaped, or there might be white creases across the tip of the nipple, or there might be wounds on the frontal surface. And this is usually because the baby is sucking or the latching is taking place in a wrong way. And this sentence is extremely important, after the baby has been released from the nipple in a normal feed, the nipple should come out of the baby's mouth intact and in the exact shape as it was before the feed began. If the nipple has changed in shape, it's an indication that the latching process is not correct. And here you can see it very clearly. Here's a a cracked nipple with a crack right in on the over the whole part of the nipple, and here you can see an abnormal nipple shape. It almost looks as if the nipple has been compressed from the sides, and this is an indication that the baby is not being latched correctly. Now, mechanical pain is nearly always related to something that the infant is doing in or with his mouth, either in a compensation for or the consequence of a suboptimal latch or suck. So the baby in a way to try and get out as much as possible if the latch is not proper, or it because he's sucking wrongly and causing abrasion, as we've said, that causes the nipple to become sore. And this might also happen, for example, in a baby who's tongue-tied, or and specifically because the tongue can't go forward in the tongue-tied baby, the nipple is not being sucked deep enough into the baby's mouth, and that causes that the baby sucks wrongly on the nipple. A shallow latch, as we've said also between previously when we did the whole latching, places the nipple too far anterior in the baby's mouth. Remember, with a deep latch, the baby's nipple goes far back to basically almost the border between the heart and the soft palate. Now here, the nipple is too far anterior in the baby's mouth, and that causes friction of the nipple by the surface of the tongue, and it presses the nipple against the hard palate, and this tongue hard palate action, if I can call it like that, causes friction on the nipple, and that causes the damage to the nipple. And how do we manage that? Now, because in most cases the mechanical trauma is caused by or associated with poor latch or poor sucking, the best remedy is to correct the position and the latch of the baby, and in the process hopefully correct the cause of the sore nipple, and in the way solve the problem. Now, if a mechanical nipple pain or damage occurs, it's also very likely that the infant is obtaining inadequate milk, and milk stasis is also increasing, with eventually the effect, the consequence that milk production is going to go down as well. And obviously the breast comfort, the mother is suffering from the nipple pain. So this is becoming a bad cycle. The baby is not latching properly. It causes sore nipples, but the baby is also not, because the baby is not being latched properly, the transfer of milk doesn't take place, and that has an influence on the nipple production. Now, a normal looking latch or sac pattern that causes nipple distortion, that the nipple comes out in an abnormal form or discomfort, is not a normal latch or suck pattern, although it might look normal. But if this happens, then it is not normal. So the best way is then to release the baby from the breast and to start over and to latch again, and to try and get the baby in a proper latch. Also, to experiment a little bit with the different positions in which the baby is being held, vertically or horizontally, a football hold or whatever, that might also improve the latch or the sucking. And it also helps often with sore nipples, because the baby, if the position that the baby is being put on the nipple, if I can call it like that, changes, it also helps with the relief of the pain. So that can make the whole situation a little bit more positive and effective. Now, the best solution for it's not a good idea to take the baby off the breasts, not to let the nipples rest, and then when the nipples are being healed, to put the baby back to the breast, because as we've said, the most important thing that we want now is to get the baby to stimulate, to be latched correctly, to stimulate the breasts so that the breast milk can be formed, enough milk can be formed, although it might be a little bit discomfortable for the mother. But if everything has been tried, if the repositioning does not resolve the nipple pain, and it doesn't help to resolve the distortion quickly, it does not help to keep on trying for extended periods, to latch the baby, because that just causes more nipple damage. And what is then might help then is to help the mother to express or pump her milk, and then to get the baby, the nipples to heal properly, and then to put the baby back on the breast. But what is extremely important here is that the baby should get this expressed milk with a cup or another device, but not a bottle, because it's so much easier then for the baby to suck on the bottle and get the milk out of the bottle. And remember, we've talked about nipple preference the previous time, and this will definitely be nipple preference. Now, as I've said, that by limiting the length and the frequency of feeds, it will not, it's the best medicine, but it's also very important to teach the mothers that the length of the feeding and the frequency of the feeding is not causing the nipple pain. So mothers might think that they need to feed the baby less often and for shorter periods in order to prevent nipple pain, but that's not prevention. That will not prevent, because the nipple pain is being caused by something else than the length or the frequency of the feeds. Then just a few words on nipple shields. At nipple shields, there's also a lot of controversial advice, research, etc., being done on nipple shields, and nipple shields should be avoided as much as possible in the case of sore nipples, because evidence has shown that it does not really help to heal the nipples faster, and because it's plastic, it can also, and it might cause that the nipples are not being dried properly, and that also can cause further damage to the nipples. It can also the mother can be advised, if the nipples are very sore, and to prevent just friction from her clothes, she can wear a nipple shield underneath her bra just to protect the nipples a little bit. But as I'm saying, that might increase the problem if that causes further to keep the nipples moist or wet. Now, if the nipple skin is cracked or abraded, or there's wounds or a crack in the nipple skin, the best is to rinse the nipple skin with clean water after every feed. But as we've said previously, do not wash the breasts with soap after every feed, because that might cause more drying of the skin, and in this case, more cracking of the skin as well. If the skin is broken, a thin coat of topical non-neomycin antibiotic can be used to prevent infection with Staphylococcus aureus, which might be a contributing factor to mastitis, which we will come to on later on. And there's no reported adverse effects of the topical antibiotic on the infant, so the baby can suck on this nipple that has been treated with neomycin ointment. It's very important to avoid the use of other nipple ointments and creams and antiseptics and tea bags and wound dressings and food-based oils and all the topical remedies that one hears so often of, and that the mother has been advised to use, because there's absolutely no evidence, real evidence from research, that any of these things can work. The only thing that the mother can put on the breast is ultra pure modified lanolin. That can be the only cream that she can use. And if the product that's been used has to be removed from the nipple before the baby can suck on it, that causes further friction and possible damage to the nipple. So that's also one of the reasons why all these nipple ointments and creams should not be used. What is the best cream or ointment to use is expressed mother's milk, to teach the mother to express a little bit of milk and onto this nipple broken skin, and to leave it open. I will come to that just now. And the fact that there are so many antibodies and anti-inflammatory factors in the breast milk helps to prevent further trauma, and it also helps with the healing process of the breast. And this works basically the best. Ice can also be used just as a kind of a local anesthetic, if it's wrapped in a cloth and it's applied to the nipple just before the baby sucks, baby starts being latched, because that's when usually the nipples are the most sore, and that can help also because it can help with the let down reflex, because it's less painful when the ice has been used. And then after the mother has been put expressed milk on her breasts, the best is to keep the nipples dry between feeds. So if she put on the expressed milk, it's good to air the nipples as much as possible, and specifically when she is at home and she has the privacy at home, which she does not unfortunately always have in the hospital. And she can also even expose the nipples a little bit to sunlight. Sunlight is a good treatment for the nipples as well, obviously only for short periods. And then very important, with this airing and the sunlight helps to keep the nipples dry between feeds, because that is very important. If the nipples stay wet between feeds, then obviously we know that the wet skin is a very soft skin, and that can also encourages cracking of the skin. So if after the mother has aired the nipple, she can use a proper breast pad to absorb the excessive milk. The breast should not be wet. Then just a few words on flat and inverted nipples. Flat nipples, the name literally tells you what it is. The nipples lie flat and are even with the surrounding breast tissue, and we get different degrees of flat nipples, where the nipple is really like in flat, and or a little bit protruding in comparison with a normal protruding nipple. And here on this right side picture, we see an inverted nipple. An inverted nipples, the definition of an inverted nipple tells us it's nipples that's been pulled inward and are tucked inside the surrounding breast tissue. Now, what is very important about flat nipples, and to a certain extent also about inverted nipples, is that we must remember that the baby does not suck from the nipple. The baby takes the nipple and the breast tissue underlying the areola into his mouth to form a teat. So what is more important than the size of the nipple is whether this nipple is being retractable, whether the baby can suck it into his mouth to stretch it out, to stretch out the tissue underlying the nipple. And the nipple is normally quite tractile, and it's easy for the baby to stretch it out to form a teeth in the mouth. So it's normally not really important, a big problem. As I'm saying here, the nipple retractability is much more important than the shape of the nipple. And what is also true is that the tractability improves during pregnancy and during the first week after the baby has been born. And as the baby sucks on the breast, it even improves more. The only real problem comes when the breast is being, there's engorgement of the breast, and the breast is swollen or very tight, and it's difficult for the baby to get the nipple into his mouth together with these underlying tissue. And we will talk about that again when we talk about breast engorgement a little bit later on. So how do we manage these flat and inverted nipples? Antenatal treatment, as also there's a lot of also controversial advice on the mother needs to pull out the nipple, stretch out the nipple, roll the nipple in order to make it more tractile. But there's no evidence that any of these methods during the antenatal period really help or improve the condition. As we've said, most of the nipples improves by themselves around the time of delivery without any treatment or antenatal care. What is very important is to build the mother's confidence, because of all these rumors and old wives' tales that with flat nipples or inverted nipples, that the mother should not be able to breastfeed. What is important is to explain to these mothers that with patience and persistence, they can also succeed in breastfeeding, especially if they can overcome these problems of engorged breasts and sore nipples, etc., in the first week 2 weeks of breastfeeding, usually then it becomes better. The moment that the breasts are becoming softer and the breast milk is being established, then it's much easier for the baby to suckle from the breast, not from the nipple itself. So the baby the latching process can be much more successful. If the baby struggles to latch himself or to attach himself well, we can also help again the mother to change her position and to change the position of the baby and to trial and error a little bit in different positions to see also whether this is not which position really helps for the baby to get the nipple to suck the nipple in more efficiently. The underarm position in some cases might work quite well. Then also specifically when the breasts are quite full or engorged or swollen, it's very important to just express a little bit of milk in the beginning of breastfeeding, just to make the breasts and specifically the breast area around the areola more softer, so that it's easier for the baby to latch or to attach to the breast. And then also under no circumstances should these mothers use a bottle if they do give the baby extra food or expressed breast milk, because again the baby sucks so much easier from the bottle and will then prefer the bottle instead of the breasts. Also, what can also help is she can express a little bit of milk directly into the baby's mouth, because we have said previously that the milk is sweet and babies like the taste of milk, and specifically colostrum, and that makes it then easier for them also to suck. And they're also less frustrated, that they can be more willing to try and suck the breast in. Sometimes shaping the breast makes it easier. On the videos that we've seen regarding latching, they have shown you how the breast can be shaped to make it easier for the baby to attach. And then, as we've said, under no circumstances a bottle should be used. Then we've said that nipple pain that's been caused, that comes later on in the postpartum period, is usually being caused by infection, and the most common infection is Candida infection, and this makes the skin of the nipple sore and itchy. And they can come usually from the use of antibiotics if the mother has been treated with antibiotics for some other reason, for example, for mastitis or some other infections. And these mothers usually describe a burning or a stinging effect or feeling, and the pain can sometimes become very severe, and they can complain about pain that shoots deep into the breasts. And they might also say it feels as if needles are being driven into their breasts. So this is a much more painful situation than just normal cracked nipples. The skin might also look red, shiny and flaky, and the nipple and the areola might also lose some of their pigmentation. I will show you a picture just now. And sometimes the nipples might just look normal, but the mothers still complain about the nipples being very sore and very painful. What is also important when the mother has this Candida infection is to also check the baby for thrush, because we all know that this is a very contagious kind of condition, and the mother and the baby might cross-infect each other. The mother should be at the most, the mother and the baby should be treated with nystatin or any other medication to treat the Candida, and then also we should advise the mother to stop using pacifiers, because that is one of the things that can spread the Candida albicans fungus very easily. And also we know that the normal I want to say medications, not medications, liquids that's been used to sterilize the dummies and the pacifiers, the Moltons, etc., are not killing. None of them are killing the Candida fungus. So it's the best to boil the teats, bottle teats, if they're being used, and pacifiers or dummies. And then very important, and we will come to it just now when we are talking about mothers living with HIV, it's very important to treat breast thrush and oral thrush in the infant promptly, and to take the infant off the breast while the mother is having mother and or baby is having thrush, because that is a very easy way, and it increases the risk of mothers transferring the HIV virus to the baby. We will talk about that in the fourth lesson. Here you can see a Candida infection. You can see how red it is, and it almost looks sore. And you can see that there's a decrease in the pigmentation here of the areola around the nipple. And that's then the end of this very sore and uncomfortable nipple pain lesson. I hope you've learned something. Complete your quiz, and then you can continue to the next lesson.